Welcome viewers to a discussion about a rare but important urinary system diseases, urethral paraganglioma. This video will explore what it is, how it develops its symptoms, diagnosis, and treatment options. Join us as we delve into this unusual condition. The exact cause of urethral paragangliomas remains largely unknown. However, like other paragangliomas, they are believed to arise from extra adrenal chromaffin cells, which are specialized cells of the autonomic nervous system. These cells, which normally reside outside the adrenal glands, undergo abnormal proliferation and form a tumor within the urethra. Genetic factors, such as mutations in genes associated with hereditary paraganglioma syndromes, may play a role in some cases, predisposing individuals to the development of these tumors. Chronic irritation or inflammation within the urethra has also been suggested as a possible contributing factor, but further research is needed to confirm this association. Urethral paragangliomas, originating from chromaffin cells in the urethral wall, disrupt the normal function of the lower urinary tract. These tumors, often highly vascular, can secrete catecholamines, such as adrenaline and noradrenaline, though this is less common than with adrenal pheochromocytomas. The physical presence of the tumor obstructs the urethra, impeding urine flow. Additionally, catecholamine release can trigger systemic effects, including hypertension, headaches, and palpitations. The local mass effect combined with potential hormonal activity leads to the characteristic symptoms associated with the disease. Urethral paragangliomas are exceptionally rare, representing a tiny fraction of all urinary tract tumors. Due to their rarity, precise epidemiological data is limited. They appear to occur slightly more often in women than in men, and are usually diagnosed in middle-aged adults, typically between the ages of 40 and 60. Although rare, it's important to consider urethral paraganglioma in the differential diagnosis of patients presenting with lower urinary tract symptoms, especially those with a history of hypertension. Symptoms of urethral paragangliomas vary depending on the tumor's size and location. Common signs include hematuria or blood in the urine, dysuria or painful urination, and urinary frequency or urgency. In some cases, patients may experience urinary incontinence or difficulty emptying the bladder completely. If the tumor secretes catecholamines, patients may also present with systemic symptoms such as hypertension, headaches, palpitations, and excessive sweating. In rare instances, the tumor can cause a palpable mass in the perineal area. Diagnosing urethral paraganglioma requires a combination of clinical evaluation and imaging studies. A thorough medical history and physical examination are essential. Urine analysis can detect the presence of blood. Cystrathroscopy, a procedure involving the insertion of a small camera into the urethra, allows for direct visualization of the tumor and can obtain biopsy sample for histological examination to confirm the diagnosis and rule out other malignancies. Imaging techniques, such as CT scans, MRI, or specialized nuclear medicine scans like MIBG scintigraphy, are used to determine the tumor size, location, and extent of spread, as well as to assess for the presence of any distant metastasis. Biochemical testing to measure catecholamine levels in the urine and blood can help confirm the paraganglioma's hormonal activity. Urethral paragangliomas do not generally fall into rigid classifications like other cancers. Their primary description is based on their location: urethra, cell origin, chromaffin cells, and behavior T benign vs malignant, although malignancy is exceedingly rare. Pathologists will examine the tissue sample to determine its cellular characteristics and assess for any signs of aggressive behavior, though true malignant urethral paragangliomas are exceptionally uncommon. The primary treatment for urethral paragangliomas is surgical excision. The surgical approach depends on the tumor's size, location, and extent. Smaller tumors may be amenable to transurethral resection, a minimally invasive procedure performed through the urethra. Larger or more invasive tumors may require open surgical excision. In cases where surgical removal is not feasible or complete, radiation therapy may be considered as an adjuvant treatment. Prior to surgery, patients with catecholamine-secreting tumors may require medical management with alpha blockers to control blood pressure and prevent hypertensive crises during the procedure. Regular follow-up is essential to monitor for recurrence. As the causes of urethral paragangliomas are not entirely understood, specific preventative measures are not currently available. Maintaining a healthy lifestyle and avoiding potential irritants to the urinary tract may be beneficial. Individuals with a family history of paragangliomas or other neuroendocrine tumors should undergo genetic screening and regular monitoring as recommended by their physician. The prognosis for patients with urethral paragangliomas is generally good, especially when the tumor is detected early and completely resected. Local recurrence is possible but uncommon. Malignant transformation is exceedingly rare. Recent research has focused on identifying specific genetic mutations associated with paragangliomas, which may lead to more targeted therapies in the future. Additionally, advancements in imaging techniques and surgical approaches continue to improve diagnostic accuracy and treatment outcomes. Patients require long-term follow-up to monitor for recurrence or the development of new tumors.